masterclass on prostate cancer. And a sec. This is our 188 episodes of multidisciplinary GU meeting under the auspices of Urology and Transplant Foundation of Bangladesh. UTFB have been conducting this type of meeting each and every week, sometimes in the fortnightly, in the form of tumor board, lecture, masterclass, interview, interactive discussions on different oncological topics for over 8 years. Due to the present reality, due to the pandemic, we are now conducting the meeting through webinar. In the meantime, we lost many of our colleagues and friends in the pandemic. We pray for their departed soul. Masterclass on prostate cancer is the prostate cancer. You know, the prostate cancer is the second most diagnosed cancer in the man, and what is estimated to be around 15% of the cancer diagnosed. It has geographical, racial, rural, and urban pathological variations, as well as a lot of controversies has been going on the screening, investigation, pathology, diagnosis, and different modalities of treatment. There are some exciting developments occurred over the last decade, so we decided to conduct a masterclass on prostate cancer. It will be an exhaustive to discuss in a single webinar, so we divided the masterclass into some modules. And recently, we also completed a masterclass on renal cell carcinoma. And in the first module, we kept this module particularly in the basic things like feasibility of screening, genomic testing, risk stratifications, biopsy, MRI, so basic stuff. And we have fortunate enough to a wholehearted cooperation from faculties of the two prime institutes in the subcontinents. These are from All India Medical Institutes and Tata Memorial Hospital. And you can see that Dr. Amol Sheth, he is the HOD and Professor and HOD of Urology in All India Medical Institutes with us today. And he will be talking around this stratification and prostate biopsy. We also have Dr. Ganesh Bokshi, who is from Tata Memorial Hospital. He's Professor of Oncology there. And we also have Dr. Santosh Menon, he's Professor of Geopathology from Tata Memorial Hospital. And Dr. Palak Potam, who is she will be discussing very interesting topics in PMRI, which is a very current topics now. And we also have speakers from this country as well. He's Dr. Pranish Shah, he's Professor of Urology, National Institute of Cancer Research Hospital. And we also have Dr. Mir Islam Haq, a consultant urologist in Evercare Hospital, Dhaka. We also fortunate enough to get Professor N.P. Gupta. He's a legendary professor, you know, he worked a long time in as a professor and head of the department at All India Medical Institute, and now he's working in Max Hospital, Delhi, as the chairman and academic and research division of urology. And we also have Professor Dr. Hemant Tangakar, and he is very known to us. He's a friend of mine in Bangladesh. Both Professor Gupta and Professor Tangakar is our friend. Long time. They visited Bangladesh different time, and they mentor us in different occasions. And he's now working in. Now he's working in a consultant surgical oncology at PD Hindustan Hospital, Bombay. We also have with us eminent oncologist, Dr. M.A. Hai. He's the currently working as director of Cancer Society Hospital and Welfare Home, and ex-director of National Institute of Cancer Research and Hospital. So our first topic is feasibility of screening prostate. So shall we discuss? Start now the topics, because.
I think
okay,
yes.
So I'll start my presentation.
That would be nice.
Dr. Bokshi is already there. Sorry, I thought that. So Dr. Bokshi will be discussing the feasibility of screening and prostate cancer and PSA and other testing, and the 4K, PHI, and polarities. Dr. Bokshi, please.
Right. So you will have to stop sharing the screen. 1 minute. I'm just sharing the screen. Am I audible?
Yes, you are.
So, thank you, Bangladesh Urological Society, Dr. Salam sir, Dr. Jahangir, and your foundation for involving me in this program. And the topic given by Dr. Salam was feasibility of screening in prostate cancer, a very hot and debatable topic even now with so many articles in literature. So I thank you. Thank Shafi too, who was with me for a year. And I have taken some slides from my colleague, Dr. Gagan, from his past presentation. So about screening, these are the normal things like what we need to see in screening is disease characteristics, the tests which we use, their characteristics, the interventions, the program characteristics, and generally the ethics of screening. So these are all important as far as any screening goes. And two prerequisites for screening to achieve in prostate cancer or any cancer for that matter. So decrease in the cases presenting at a late stage to reduce cancer mortality, and earlier treatment options must confer an advantage over treatment initiated later in the course of disease. So currently we use these two tests, DRE, which has a 40-50% positive predictive value, and PSA. PSA has a very high specificity, as we all know, about 90+%, 91%. And the sensitivity varies from 16% to 50% where in high-grade cancers. So I thought I took up this article from NEGM, which was in 2020 just published, and then went ahead with it. So reconsidering prostate cancer mortality, the future of PSA screening, and what can be added, subtracted, and what can be done. So 1970s and 80s was the time when TURPs increased for benign, and then the diagnosis of CA prostate started coming in. So by 1986, half the prostate cancer diagnoses were by TURP. Later, the PSA at the same time was developed, and from 87, early 90s, the screening was PSA based. And around at that time, more than half the men who have died after 60 years of age from some other cause also had pathological prostate cancer. So that is how the curve went from 1950 to peak at around early 1990s, which coincided with the initiation of widespread PSA screening. And both increased incidence as well as the mortality. And later on, as per the developments came, it again has sloped downwards. So observations over the years where many men with PSA detected prostate cancer were subsequently observed to survive 15-20 years, often with minimal treatment, and many ultimately have died from something else. Most PSA detected prostate cancers thus act more like a chronic disease than aggressive malignancy, although aggressive malignancy happens in a cohort of patients. And PSA screening very often finds well-differentiated prostate cancers. Poorly differentiated cancers, the one that actually usually kill men, are found much less frequently. In fact, some men with the most poorly differentiated have a problem with the PSA level also. So after 1987, 1993, and these two big trials were initiated. We all know about these trials, so I'm not going to go into detail about this. And the data started coming out around 2012. So PLCO was an American trial that we all know, and the ERSPC was a European subcontinent continent trial, multi-center. And offhand, we saw when it was first reported that there was a relative risk reduction of 21%. And there were smaller cohorts where the trial was done more properly or tightly, we can say, as Göteborg in Sweden, and where the relative risk reduction of mortality was 44%. So that's quite a high number. And now we have the late data. At 16 years of follow-up, if you just see one screening around attended by the participant, there was a 25% reduction in cancer-specific mortality in ERSPC and 48% with more than 2 rounds. So number needed to screen at 16 years in the ERSPC was 570, and number needed to treat was 18 to prevent one cancer death. If you go on the Göteborg study 18-year results, the prostate cancer mortality, there is an absolute reduction of 52%, which is quite high. To prevent one death from prostate cancer, number needed to screen was 231, and number needed to treat or diagnose was 10. So systematic PSA screening demonstrated even greater benefit in prostate cancer mortality for men between 55 to 59 and also those with less education or any other factor. So it concluded as these data corroborate previous findings that systematic PSA screening reduces prostate cancer mortality and suggests that systematic screening may reduce socio-demographic inequality in prostate cancer mortality. So with this, there is a good risk of overdiagnosis, and we all know about it. So diagnosis in men who would otherwise not have any clinical symptoms or suffer in their lifetime. So the ERSPC, if just to quote, the overall rate of overdiagnosis was 50%. And as you see in the other components of the other trials. If we see the ERSPC versus the real world data, the red one is the kind of real world data. And there is a, if you see the prostate cancer mortality, there is a 37% decrease in mortality in most favorable of three major trials. So ERSPC, PLCO, and there was another trial. So another two trials showed that there was reduced risk of death associated with RP or RT. So it started with the PIVOT trial, then the SPCG trial, and the best of them was the PROTECT. So it showed reduced risk of death associated with RP or RT, at best minimal, not statistically significant, and it requires more than a decade to appear. Incidence of metastatic disease, which has also decreased more in practice than in the ERSPC, if you see the second graph, minus 62%. So it reflects the change in the diagnostic process also. Decreasing incidence of metastasis is evidence that cancers destined to cause death are also being diagnosed earlier due to this screening. If you see further, at that time, the USPSTF, the recommendation changed to D. They recommended against the service of screening. There is a moderate or high certainty that the service has no net benefit and the harms outweigh the benefit. And from 2012, the new recommendation was used. So if you see the further period up to 2017, there was an increase in distant stage prostate cancer in men more than 75 years, as also twofold increase in the metastatic disease. And there were a lot of cancers with higher stages. So if you see this, another paper, this has been published in 2020. And this says about what happened after USPSTF recommendations against screening. So previous studies, as we all discussed up till now, did show that initially incidence rates declined for local stage, while the rates increased for distant stage, following the USPSTF recommendations against for PSA-based screening for men aged more than 75 in 2008 and for all men, which happened in 2012. And then there is the recent data which goes through. If you see through the years 2005, 8, 12, 17, for local stage in men aged more than 50 years, statistically significant decreased. The local staging was decreased by 6.9% per year from 2007 to 16. As also the regional stage incidence rates statistically significantly increased by 11.1% per year, and the distant stage disease incidence rate statistically again significantly increased by 5% per year. So regional and distant stage prostate cancer incidence continue to increase, and they still might have crossed or not crossed. The data is not clear in them, but they started after the 2012 recommendations. And during the same time, in these 5 years, the PROTECT trial came, and it concluded that at the median of 10 years, prostate cancer specific mortality was low, irrespective of the treatment, and kind of active monitoring, which can be a loose term of active surveillance, can be used as a very efficient treatment modality. So the idea was whether to screen or not screen, but to treat or not to treat. And the active surveillance rate has increased in US, I mean not in our country, from 14.3% in 2009 to a good 40% in 39, now even more. So in 2017, with all these things taken into consideration, the stage migration, the more finding of advanced disease, and these treatments coming into place, the USPSTF again changed the recommendations for people aged from 55 to 69 from D to C. So this was what happened actually the 13 years, the recommendation D, with the long-term results of these trials of ERSPS, PLCO, concerns of stage migration, as well as proven oncological safety of active surveillance. The recommendation again changed to C. And then we have to ask a question, why not to screen? Or the answer lies, why not to advocate it? Because every individual clinician wants to do it in his or her possible manner. So decrease in prostate cancer mortality has been achieved at enormous human costs. Incidence had been soared to 200 per 1 lakh population, and more than 1 million men were diagnosed with clinically insignificant cancer, receiving treatment for pathologic findings not destined to cause symptoms or death. PSA screening represents a textbook case of overdiagnosis and overtreatment in medical care. On that basis, US PSTF was right maybe not to recommend it. Just a decreasing CSS is misleading, and screening should reliably translate into increased longevity, which requires a reduction in all-cause mortality. So what could have happened? Screening may more easily change the distribution of causes of death than extend life because of a certain cause. Prostate cancer in elderly, the median age at death was 80 years. So combination of a high burden of competing risks for death and high rates of intervention related complication conspires to limit any reduction in the ACM offered by screening. Again, quality of life is equally important post-therapy. So pain with metastatic disease, complications of radical prostatectomy or radiation do count. So screening then in that sense can be a disservice, because these programs necessarily recruit many people to potentially help a very few population. Screening efforts may distract primary care providers from other more important issues in health, and another externality raises medico-legal concerns. Efforts to promote screening, and how the statements goes is that missing early prostate cancer. This is how the people advertise about screening. So this can finally lead to a medico legal suit in some people. So how do you see benefits and harms of 1,000 men screened? 720 can test negative, 178 have false positive, 4 have biopsy complications, 102 diagnoses of prostate cancer, 33 do not cause illness or death, 5 die actually of prostate cancer despite screening, 1 escapes death because of PSA screening. And this was published by the Canadian Task Force on Preventive Care in 2014. So that is how out of 1,000, the calculation happens way down. The balance is about catching significant prostate cancer using good test treatment, stage migration towards lower side, against over-treatment, over-diagnosis, and treatment-related quality of life harm. So we continue to argue against contemporary PSA screening, particularly in light of our volume-driven healthcare system. And we must acknowledge our position reflects a value judgment. A few people receive substantial benefit, while many more are exposed to needles, biopsies, operations, and other sources of financial stress. So these are the pros and cons. And if the patient asks us, what the doctor can say has definitely changed from 2012 to 2017. So if we are yet to screen, then what should we do? The thresholds for biopsy would be both time-dependent, age-specific, resulting in complex algorithms that should be hardwired into the tests, or more complex PSA testing, adjusting for prostate volume, restricting biopsies to lesions visible on MRI. So these are few tests which I would discuss. In very short, PHI, Prostate Health Index, has been approved by US FDA for PSA level between 4 to 10. And it is a blood-based multi-biomarker test with the complex algorithm as given. And a recent meta-analysis of 16 published studies did say that a pooled sensitivity of 0.9 versus a pooled specificity of only 0.17. So in high-grade disease, the pooled AUC for PHI was only 0.67. And in a recent multi-center European prospective trial of 489 men, the PHI test was found to be a significant predictor of unfavorable histopathology at surgery. However, the authors did find that PHI added very little net benefit. This is how PHI score comes, the PHI range. And if I roughly say, for example, a patient with a PHI result below 27 has a 90% chance that his prostate biopsy is going to be negative. Going to the slightly better test, which is the 4K score test, the US FDA has approved this in 2019, and insurance pays for it in the US. So it is an accurately identifies the risk of aggressive prostate cancer, an important clinical role as a reflex test prior to proceeding with initial prostate biopsy. It measures 4 prostate-specific biomarkers: total free PSA, intact PSA, and HK2. Clinical information like age, biopsy history, digital rectal examination, and a complex algorithm again. So probability score ranging from less than 1 to more than 95 reflects a probability that man will have aggressive cancer defined as lesion 7 or greater. And two US-based prospective validation studies have happened where the combined sensitivity of 94% and NPV of 95% for a cutoff of 7.5 has been used. So application of the 4 kallikrein panel to 1,000 men with elevated PSA would result in 513 avoiding a biopsy and missing only 12 of 100 Gleason score more than 7 cancers. And if you see the percent reduction of various biopsies or radical prostatectomy, in the last column, it has been seen, noted in all these studies. So if you see, this test has been probably advocated by many people in the US. And what further 4K score did was it also gave us an overall risk of distant metastasis. If you see the in-between curve, so it was able to discriminate between those who need further testing due to high risk of prostate cancer progression to metastasis and death. And long-term outcomes data have displayed that biomarkers in the 4K score test can predict the risk of prostate cancer metastasis up to 20 years in advance. A final attribute of 4K score test is unique, is the accuracy of its individualized probability prediction. The test result is a personalized positive predictive value of finding lesion more than 7 on biopsy of prostate. This provides the patient and the clinician with quantifiable information. So for example, if a healthy person comes with a score of 6 and has a good life, he is a young person, then we can advocate a treatment for him and a biopsy and treatment. Whereas if a slightly elderly moribund person comes and if his score is even 10, 14, then probably we'll have to take a clinical call. There is this another test available, PCPT, Prostate Cancer Prevention Test, Risk Calculator version 2. You just have to fill in details as I have filled in here. Race, age, PSA, family history, digital rectal examination, prior biopsy, and you just calculate, you get such an answer. 28% chance of high grade, 23% chance of low grade, 49% at the biopsy is negative. So you get, these things are also available. This PCPT risk calculator was published in 2014 and it also helped the clinician. So in a small comparison with 4K score, the 4K score was significantly better than the PCPT calculator, but the calculator is very easily available. Now, what about polygenic risk-tailored screening for prostate cancer? So something related to the genetic setup. So why this study was done? To develop a tailored screening program for prostate cancer on the background of overdiagnosis and overtreatment and the costs, and with the thought that it may improve the balance and benefits harms of a screening program for prostate cancer. So what was found? It was found that a polygenic risk-tailored screening program might reduce overdiagnosis, maintain the mortality benefits of age-based screening, and improve cost-effectiveness of a screening program. The ideal threshold for risk-tailored screening will depend on a societal judgment again, and future prospective trials are needed for this. What about MPMRI? It also helps us, but it is clearly not recommended in the first line. If you read, do not use MPMRI as an initial screening tool, but we all know that it helps us in certain advantages. So take home message, use effective organized screening. We will never have perfect data on the effectiveness of various screening approaches in reducing cancer-specific mortality. The trials required are too big and take too long. The conventional goal of screening to maximize cancer detection is quite wrong. The appropriate goal is more complex. Identify the few cancers that matter while not disturbing the rest of the population. In contemporary era, solutions to mitigate overdiagnosis and overtreatment. Overdiagnosis by specialized PSA tests, MPMRI, molecular tests, and overtreatment by active surveillance, watchful waiting. Taken together, these instruments could assist physicians in discriminating between indolent and aggressive prostate cancer, minimizing the human sacrifice to save one life. Tests like these, it seems, are shortly going to be available, although I have put this just as a funny slide. Prostate cancer and dog sense smell, and there was this reported earlier in 2012 and 13. And this particular slide I put because in the end they had written, we can further use specialized analyzers of electronic nose type as well as gas chromatography with mass spectrometry. All are of scientific and practical interest. These are the EAU 2020 guidelines, which say do not subject men to prostate PSA testing without counseling them on potential risks. offer an individualized risk-adapted strategy for early detection to a well-informed man and life expectancy of 10 to 15 years. So that is the catch, 10 to 15 years of life. Early PSA testing to men more than 50 years, men more than 45 years with family history, African descent, carrying BRCA2 mutations. So that is about it. Questions?
Thank you.
Yeah, I'll just stop sharing.
Dr. Professor Bakshi,
Yeah,
we have some
thank you.
questions for you. May I show you my screen?
Please, sir.
Right. First of all, probably have already actually spoke about the high risk group. What type of personal take on the on for this type of screening, screening on this type of group of patients. So we have already told in the last slide.
Yeah.
So I think just sharing.
So the high risk group still entails those with family history, and those, I mean, African descent is what is not applicable to our continent, but mainly the other thing is the one with the BRCA2 mutations. Now that NCCN has said that in the guidelines where localized high risk and locally advanced, and further we can test for germline or somatic mutations.
Another thing is the cost effectiveness of new tests you are suggesting. Are they cost effective for screening purpose? Because the 4K, PHI, and
so I guess they should be considered cost effective because I've gone through that literature, and because they help us choose, or they help us reach a patient who is a high risk patient, the patient with a clinically significant prostate cancer. So we would then go for the other side. It will help us avoid some biopsies, so it will be cost effective.
Is there a role of 4K to reserve the prostate biopsy in active surveillance group? There's another question to you.
So there is a role. As I showed the data of 4K square, it can tell us with respect to its score that the reference score was 7.5, but it can tell us with respect to the score whether this person will be less aggressive or more aggressive, and even predict about the chance of metastasis.
Right. Can I come to the panelist, Professor Gupta, sir? Do you think that some sorts of screening is feasible in this type of part of the world? And if it is, what type of screening you suggest?
See, I will tell you, I have controversial marker for screening for the cancer prostate. There is no doubt about that. And last 30 years, I will say, there is enough literature. And we can debate that. PSA marker has also served the population like anything, because we can't replace PSA. So the current practice, what we are doing, and what the guidelines have been given to you, that high risk group and above the age of 50, those who have a longevity of 10 to 15 years, you do a counseling and do one PSA test only. I don't say that you have to repeat it again and again. After seeing one value, then you decide what is to be done next. I'll give you an example. If somebody has got a PSA of 0.45 or 0.5 or less than 1, these are the cases, they are very unlikely. So we, in this group of patients, we can wait for 2 or 3 years to get a repeat PSA. Whereas if somebody has got a value of 2 or 3, then you do a digital rectal examination, of course, and keep them under active surveillance, I will say, or watch, and repeat their PSA maybe once a year. And if the PSA is rising, and in India, you know, we had this chronic prostatitis and all that chronic inflammation in our developing countries. So we are not worrying this PSA of 4 or 5 now. We wait up to the PSA of 6 actually, you know. And this has been debated in our society also. And if PSA is further going above 6, then we do. Now the last question which you have put, MP-MRI. Yes, all these PHI, 4K, Polaris, they are, PHI is available in India. It costs 4,000 or 5,000 rupees. Other tests are very costly. I have got some patient who went to USA and they got their Calicrine and all that. So they cost around 2 lakh to 4 lakh rupees only for a test, and which is also not going to give you an accurate value. So the practical thing is that we do multi-parametric MRI, and that gives us a lot of information. And if everything is normal there, then we can again wait that there is a scoring is higher side, like then only we say thyroid is scoring 3, 4, then we say go for biopsy. So that is the approach what we are following at the moment. So I say PSA, though it is controversial, but certainly it has got a big value, especially in our developing countries.
Professor Tunkakara, would you comment something on this type of?
Yes, I think we need to understand very clearly that the aim of screening is not early detection. That's an important prerequisite. The aim is to reduce the mortality. So if you want to advocate this kind of a screening program in our part of the world, then I don't think it is really justified. First of all, prostate cancer is not as common a cancer in our country as it is in the West. And secondly, it is not cost effective even in those countries. Even to say there is a significant overdiagnosis and overtreatment. So I don't think we should, as a rule, as a routine, advocate prostate cancer screening in this part of the world. It should be an opportunistic screening, that those patients who are high risk or those patients who come to your OPD, although it's not called screening actually, but these patients you should monitor because they're symptomatic. I think asymptomatic patients who are not high risk, I don't think we should really go after them with a screening program, whatever tool. Secondly, the second point which was brought out in the US was that because they stopped screening, the rate of metastatic prostate cancer increased in 5 years, that too. Basically here, if you stop diagnosing more and more asymptomatic or low risk prostate cancers, then the denominator is going to become less, and it will, fallaciously show you that the metastatic cancer patients are increasing. It is not a true increase. It is an increase in the percentage, and that's because the low risk patients have now come down. So there is nothing to worry about as far as metastasis are being increased or anything like that. I think that's going to be the same. So in our part of the world, I think we should just continue as what we are doing, that high risk screening, and patients who are symptomatic, you follow them up.
Can I have a point?
Yes, please. Very, very quickly, sir, because we are running over the time.
Very short address is, if we can use the social media and award the people that in this age, prostate cancer is fairly common. You do at least one test, that is PSA. If it is elevated, then contact your urologist or nearest doctor. Can you do that? Question to the House and the panelists.
I think
so another panelist. Sir, carry on.
We should not do that, Dr. Salam.
Yes, sir.
We should not scare the population, and we should not give this message to the media that the incidence is very high. I think so. What Dr. Tangaonkar said, the opportunistic screening, that is what we are following in this country, and high risk cases. And as I told you, the duration of your checkup of the PSA can be variable depending upon his baseline level of the PSA. I don't think so. We should.
Thank you very much. The message is understood. Yeah.
Thank you. May I take a last comment from Professor M.A. Hai? Is he with us? I'm not finding him. I don't. So if he's there, please respond.
He was trying to get in, but
I've just joined. I couldn't join earlier.
All right. So just make a quick comment, sir, if you want. About the PSA screening and how we can diagnose in this country a little bit earlier, because we are getting the patients in late stage still. As you see in the Indian Institute.
Let's say we can do only PSA, otherwise we don't have a GR and PSA. This is the only tool we have. And only thing we can go for ultrasound and imaging also.
All right, sir.
PSA is also very controversial. Very, I think it's a very controversial thing. PSA and DRA is, I can recommend what you can do.
So we are running out of actually over the time. So may I ask the next speaker, Dr.
Ehteshamul Haq.
Dr. Shamul to talk on. Can I find Dr.
Yes, sir. I'm.
Yes, are you here? Are you there?
Yeah,
So
I'm
come up
here.
with your topics. Yeah.
Can you hear me?
Yes, yes, we can.
Yes. Okay.
So your topic is genomic testing in prostate cancer patients and its importance on treatment. I have to stop sharing, so you can start sharing your screen.
So
this is a very new subject topics, and we confess that Dr. Esteban Haq said that he has very little experience on this experience. So we just asked him to bring the topics forward so that our actually learned panelists and other person can actually contribute much if they want to be, or what is actually relevance at this moment in this part of the world. That's why we just want him to bring the topics. So he has actually dare enough to talk on this matter. So I think he'll bring the matter very nicely.
thank you, sir. Sir, can you see my?
Yeah, we can see you.
Okay, thank you very much. Today's topics is genomic testing in prostate cancer patients and its impact on treatment. Before going to the subject, I like to show this slide because this little girl trying to enter into the room, she is very afraid, very shy, but very enthusiastic to watch inside the room. So when Professor Salam asked me to present these topics, my condition is something like this. So, but I am now very enthusiastic because many big mentors are around me. So I think I can bring up the topics to you. So no delay. Before going to the topics, I want to show some key points of prostate cancer. A genetic contribution of prostate cancer risk has been documented, and knowledge about the molecular genetics of the disease is increasing. Several genes and chromosomal regions have been found to be associated with prostate cancer in various studies confirm modest to moderate lifetime risk of prostate cancer. Epidemiologic and molecular evidence suggest that prostate cancer has a strong familial component, as demonstrated by germline genetic analysis. The first reports of familial clustering were published in mid-20s and suggested that the risk of developing prostate cancer was higher in those with an affected first-degree relatives. Subsequent case control and cohort studies have confirmed this observation. Information is limited about the efficacy of commonly available screening tests such as digital rectal examination and prostate-specific antigen levels in men genetically predisposed to developing prostate cancer. Initial reports of targeted PSA screening of carriers of BRCA pathogenic variants has yielded a higher proportion of aggressive disease. Based on the available data, most professional societies and organizations recommended that high-risk men engage in shared decision-making with their healthcare providers and develop individualized plans for prostate cancer screening based on their risk factors. The 4 important recognized risk factors for prostate cancer in United States are age, ancestry, family history of prostate cancer, and germline genetic variants. Prostate cancer is rarely seen in men younger than 40 years. The incidence rises rapidly with each decade thereafter, and the overall risk of prostate cancer is 1 of 9 male persons. Approximately 10% of the prostate cancer cases are diagnosed in men younger than 56 years, represent early onset of prostate cancer. Data from the Surveillance Epidemiology and End Results program show that early onset prostate cancer is increasing, and there is evidence that some cases may be more aggressive. There is a worldwide trend towards the increase in the number of men younger than 40 years diagnosed with prostate cancer, often with poor prognosis. Because early onset cancers may result from germline pathogenic variants, young men with prostate cancer are being extensively studied with goal of identifying prostate cancer susceptibility genes. The risk of developing and dying from prostate cancer is very much higher in blacks, intermediate among whites, and low in Japanese and Asian people. Conflicting data have been published regarding the etiology of these outcomes, but some evidence is available that access to healthcare may play an important role in disease outcome. Prostate cancer is highly heritable. The inherited risk of prostate cancer has been estimated to be as high as 60%. As with breast and colon cancer, familial clustering of prostate cancer has been reported frequently. From 5 to 10% prostate cancer cases are believed to be primarily caused by high-risk inherited genetic factors and prostate cancer susceptibility genes. Results from several large case control studies and cohort studies representing various populations suggest that family history is a major risk factor of prostate cancer. A meta-analysis of 33 epidemiologic case control and cohort-based studies has provided more detailed information regarding the risk ratios related to family history of prostate cancer. Risk appeared to be greater for men with affected brothers than for men with affected father. This is the slide showing some relative risk factors and history of prostate cancer. Potential modifiers of prostate cancer risk are endogenous hormones, including both androgens and estrogens, like influence prostate carcinogenesis. It has been widely reported that eunuchs and other individuals with castrate level of testosterone before puberty do not develop prostate cancer. Some investigators have considered the potential role of genetic variation in the androgen biosynthesis and metabolism in prostate cancer risk, including the potential role of androgen receptors. Excess risk of second primary cancers, including cancers of the small intestine, soft tissues, bladder, thyroid, thymus, melanoma, prostate cancer diagnosed in patients aged 50 years or younger, associated with increased risk of pancreatic cancer as well. The underlying etiology of developing a second primary cancer after prostate cancer may be related to various factors, including treatment modality. More than 50% of small intestinal tumors were carcinoid malignancies, suggesting possible hormonal influences. The excess pancreatic cancer may be due to pathogenic variants of BRCA2. The risk of melanoma was most pronounced in the first year of follow-up after diagnosis of prostate cancer, raising the possibility that the result of increased screening and surveillance. One Swedish study using the nationwide Swedish family cancer database assessed the role of family history in the risk of second primary cancer after the prostate cancer. So identifying the genes and inherited variants associated with prostate cancer are linkage analysis, case control studies, administered mapping, genome-wide association studies, inherited variants associated with prostate cancer aggressiveness. These are the tests usually performed to assess the prostate cancer risk. These are the genes BRCA1 and 2 mismatch repair genes, HOXB13, ATM, CHEK2, TP53, NBS1, and epithelial cellular adhesion molecule. So after this brief overview, I like to show the recommendations, the latest recommendation from NCCN guideline of prostate cancer. Germline genetic testings are recommended in high risk, very high risk regional or metastatic prostate cancer. Ashkenazi Jewish ancestry, family history of high risk germline mutations, a positive family history of cancer, that is brother or father of multiple family members, not clinically localized, grade group 1, at less than 60 years or died from prostate cancer. 3 or more cancers of the same side of the family, for example, bile duct, breast, colorectal, endometrial, gastric, renal, melanoma, ovarian, pancreatic, prostate, small bowel, all urothelial cancers. Genetic testing for germline variants should include MLH1, MSH2, MSH6, PMS2, and homologous recombination genes BRCA1, BRCA2, ATM, PALB2, and CHEK2. And the recommendations for somatic tumor testings are DNA repair genes such as BRCA1, BRCA2, ATM, PALB2, FANCA, RAD51D, CHEK2, CDK12 in patients with metastatic prostate cancer. Tumor testing for MSI-H or dMMR can be considered in patients with regional or castrate-naive metastatic prostate cancers and recommended in patients with metastatic CRPC. At conclusion, I like to mention some points that germline mutations predispose to prostate cancer and have impact on clinical management. Platinum-based therapies, immunotherapies, or other inhibitors for management of CRPC who have germline mutations may lead to improved long-term outcome. Improved access to genetic counseling, screening, and treatment for men with germline mutations yield significant long-term benefits to the patients with prostate cancers. Thank you very much for your patient hearing.
Right. Thank you, Dr. Etashamul, for your delivery. And may I request a very quick one because we are running out of time. So may a comment from Dr. Tungakara. Just quick, what is the present situation here in this part of the world about genetic testing? Can you unmute, Dr. Tungakara? Can you unmute yourself? I mean,
Dr. Jangir, in the meantime, we can say our status.
Yes, sir, we are running out of time. So just one, can you say just quick word?
We have started the work, but uniformly it has not been tested. But the high-risk prostate cancer and the family, those who have got family history, they are also being screened nowadays. But these tests in the pathology are evolving.
Yeah, Salam sir, can I add a practical point?
Yes, sir.
Yes.
Yes, good evening, good afternoon, everybody. I'm Dr. Menon from Pathology Department in TMH. So the most practical important point is in a metastatic setting, we get tests for MMR.
Yes.
Tumors which have loss of MMR or which are MMR deficient, they are candidates for PDL1 therapy. So that's one practical point in prostate. The other thing is ARV7 testing. That's androgen receptor variant 7. Positive tumors, especially in metastatic setting, done on a liquid biopsy, will definitely help in planning whether the patient should be given docetaxel or enzalutamide or abiraterone. So patients who are positive for ARV7 mutation don't do well with enzalutamide and abiraterone, so they would go for docetaxel. So that's practical importance of genomic testing in prostate cancer. That's the most current scenario which has been practiced.
Good, thank you.
Right. Actually, who are the people? We probably get some answer from Menon's comment. Professor Tungagora, do you like to comment on some point on this? I mean, how can they be cost effective, and should we keep germline testing as a routine evaluation of CAP?
I don't think it is cost effective. As Dr. Santosh Menon said, that the value is really mainly in the metastatic setting. In those patients who can afford, maybe those patients can have this thing. But routine, I personally, in my practice, do not do genomic testing.
Right. Okay, thank you. So, I mean, our next speaker is Dr. Amol Shed, who will be talking on risk stratification and prostate biopsy. May I request Dr. Amol Shed to start sharing the screen and start his lecture.
Thank you very much. I'll just begin my presentation.
Can you start sharing your screen, please?
Has my screen
yes.
Can you see my screen?
This is black now. I mean, it's still not visible. We are also not seeing you as well. It says that you have started sharing, but it is not showing here. You can double click the thing.
What does screen share? No. No. Is it there?
Not really. No, we can see you, but we cannot really see your slides.
Can you see now?
No.
No.
No, not really. I mean,
not yet, sir. I think internet is taking time.
Okay.
Professor Amol, you can continue to speak about it, and we can hear. Let the slide
actually
come.
Meanwhile, can I Bangladesh? Abdul Salam and Urology Federation for giving me this opportunity.
Your connection is not also very right. I mean, we cannot really hear you very clearly.
Neither the screen is visible nor audible.
Yes, a broken tonation.
Now, we can see each other quite easily, but Dr. Amulesh is not audible or screen is not visible. Yeah.
জাহাঙ্গীর ভাই আপনার স্ক্রিনটা শেয়ার বন্ধ করেন।
আমার স্ক্রিন শেয়ার বন্ধ আছে তো।
না, আপনাকে দেখা যাচ্ছে।
আপনাকে দেখা যাচ্ছে।
আমাকে দেখা যাচ্ছে, মানে এটা তো দেখাতে পারে, আমি কিন্তু
Dr. Jahangir, you stop your screen. Amlesh, first you open your slide, then share the screen.
জাহাঙ্গীর ভাই আমি চ্যাটে একটা কোশ্চেন দিয়েছিলাম, একটু প্লিজ আস্ক দি স্পিকারস দ্যাট কোশ্চেন।
Or we can go to the next speaker then, while Amlesh can set up the things.
May I request Dr. Parashish Saha to very quickly on evaluation and prostate cancer Bangladesh perspectives.
Okay.
If Dr. Amalesh is not there. No, but Dr. Amalesh. Can you share your screen? Because if two person started, then we cannot really.
Jangir, can you see my screen?
I can see your screen. I can see.
Okay. Shall I start?
Yes, please.
Okay, Assalamu alaikum, namaskar, and very good afternoon to everybody. Our topic is evaluation of prostate cancer Bangladesh perspective. This is our National Cancer Institute where I am working. Actually, carcinoma prostate, it has significant geographical and ethnic differences. Men in developing countries learn to present with advanced disease compared to United States men. We are happy to see the position of Southeastern Asia at the bottom of the picture with 12.7 incidence and 5.4 mortality per 1 lakh people. This is the NCCN guideline for initial prostate cancer diagnosis. In Bangladesh, our usual practice is to follow the standard international guidelines. Due to some unavailability of facility in somewhere and sometime, we have to customize the protocols. Now, how our patient presents? This is an observation in our National Cancer Institute. The prostate cancer patients, less than 5% are asymptomatic, around 50% with lower unit tract symptoms, urinary retention, sometimes obstructive uropathy, and even the renal failure. 40 to 50% with the features of advanced diseases. And our approach to patients, first of all, is a detailed history and thorough physical examination of the patient, with including family cancer history, history of prostate disease, race, family or personal history of germline mutations, and medical history of any medication. Our next step is digital rectal examination. DR is performed usually at the end of the physical examination. Most prostate cancers are located in the peripheral zone and can be detected by DRE when the volume is more than 0.2 ml. An abnormal DRE is associated with an increased risk of a higher International Society of Uropathology grade and is an indication for biopsy. This RCT observed that DRE may be useful in more selective screening procedures to decrease unnecessary biopsy and overdiagnosis. Next step is biomarker assessment. We are able to do only PSA or PSA derivatives assessment in our country. Let us see what NCCN panel recommendation about the PSA. Baseline PSA testing for healthy oil-informed men aged 45 to 75 years based on RCT. Biopsy should be considered in those 45 to 75 years with repeat PSA more than 3. Consideration may be given to biomarkers that may improve biopsy specificity, such as percent-free PSA, 4K score, prostate health index before biopsy in men with serum PSA level more than 3. Confirm MDX and PCA3 are also option. Consideration of MRI targeting as an addition to TRAS or transperineal biopsy. And our next step is prostate biopsy. It's a shared decision-making procedure. The need for prostate biopsy is based on PSA level and or suspicious DRE and or imaging. Risk stratification is a potential tool for reducing unnecessary biopsies. Ultrasound guided biopsy is now the standard of care. In our settings, we usually do TRAS guided 12-core biopsy, sometimes MR cognition biopsy, and in some of our peripheral centers, they are still doing digital guided sextant biopsy where TRAS is not available. Risk stratification helps to decrease the rate of poor prostate cancer outcomes and associated mortality worldwide. This is the guideline for risk stratification. We usually try to follow the NCCN guidelines. Now, we go for imaging of staging evaluation. This can be done anatomically or functionally. Anatomic imaging includes plain film radiographs, ultrasound, CT, and MRI. All are available in all our centers. And functional imaging techniques include radionuclide bone scan, PET CT, and advanced MRI. Fortunately, all these armamentarium are present in our country. And we do T-staging by ultrasound, usually by TRAS, and which detects only 60% of tumors. 40% are undetectable due to isoechogenicity, and combined DRE and TRAS can detect T3A prostate cancer more accurately than either method alone. Neurovascular bundle invasion can be predicted, and ECE also can be predicted by 37 to 83% in different settings. Now come to the T-staging. We usually use MRI and in some cases CT for T-staging. In our practice, we use MP-MRI for probable clinically significant disease detection in raised PSA with negative TRAS and DRE. In MRI cognitive biopsy, and in case of whole body MRI to detect bony mass. And staging. Abdominal CT and MRI indirectly assess nodal invasion by using lymph node diameter and morphology. However, the size of non-metastatic lymph nodes varies widely and may overlap the size of lymph node metastasis. CT and MRI sensitivity usually less than 40%. Still, gold standard for any staging is open, laparoscopic, or robotic extended lymph node dissection. This is a meta-analysis and systematic review this year. We found gallium level PSMA PET was more effective weapon for predicting the lymph node metastasis prior to radical surgery. And last staging is M staging. Nuclear bone scan has been the most widely used method for evaluating bone metastasis of prostate cancer. And bone scanning should be performed in symptomatic patients independent of PSA level, ISUP grade, or clinical stage. And fortunately, bone scanning is available in all our centers of Bangladesh. This is another systematic review and meta-analysis comparing PSMA, PET-CT, MRI, bone scintigraphy in the diagnosis of bone metastasis in patients with prostate cancer. They found that PSMA PET-CT had the highest per patient sensitivity and specificity in detecting bone metastasis with prostate cancer. And finally, after tissue diagnosis, possible risk stratification, and staging evaluation, our usual practice is to submit the patient in multidisciplinary tumor board for next management decision. In our capital, Dhaka city, National Cancer Institute, Urology and Transplantation Foundation, and Medical University runs separate uro-oncology unit. and offering treatment through multidisciplinary tumor board. Outside Dhaka, management by individual decision, or if possible and feasible, they refer the patient to higher standard. This is all about our perspective for evaluation of prostate cancer patient. And with these few words, thank you all. Stay safe. Thank you.
Can I try now? Is it possible? Dr. Jahangir?
Thank you, sir. Please unmute yourself.
Jahangir bhai, unmute karen.
Where it is. Can you hear me now?
Oh, yes.
Yes.
Right.
Yes, loud and clear. Can hear you.
After this talk, Professor Menon will talk again. If we can establish connection with him. But now, can I bring some to our more question and comment for this discussion?
Dr. Amol Sheth is also ready.
All right, fine.
Professor Amol is ready.
And I have few questions to arise. There are some questions from the audience as well as the you have some. So may I ask Dr. Professor Pranashish, do you not recommend any pre-biopsy MRI in your clinic or in your setting, or you just go for trus biopsy? Hello?
Hello.
Can you hear us?
Yes. Can you hear me?
Yes, I can hear you.
Sometimes we advocate pre-biopsy MRI. That means when persistently raised PSA with negative trus and DRE, to see the clinically probable significance of tumor.
May I request Professor Gupta sir to talk about what are the status of doing pre-biopsy MRI in case of raised PSA and impumpable prostate or in suspicious of prostate cancer?
See,
can you hear me?
When we have a patient with the raised PSA and we suspect that he has got cancer prostate, we do a per rectal examination to see whether patient has got a palpable disease or patient has got extensive disease which is fixed up to the pubic bone. That information can be achieved only by doing a rectal examination. Then we see the PSA level. If PSA level is very high, more than 100 or something like that, or patient has got a palpable disease, then there is no role of pre-operative MRI. We can straightway go for a trust-guided biopsy. And after the histopathology report, we can straightway go for a PSMA PET-CT. That is our practice in India now, and that gives us the metastatic stage. On the other side, if we have a patient, we suspect a localized disease, there we advise multiparametric MRI. That helps us in having the pyramid scoring also, plus the local staging. And this pre-op MRI help us in planning of our robotic radical prostatectomy surgery also. So that is the advantage of doing a multiparametric MRI. So multiparametric MRI, it was started for staging.
Hello.
But nowadays it has got of the cancer prostate. Only thing, one or two more points I like to highlight on the Dr. Saha's lecture. The algorithm has little bit changed nowadays. You know, now for example, the trust is used only for trust guided biopsy. We are not doing trust for diagnosis of the cancer prostate. And second thing is that, as I said, if I have a patient suspicion of a metastatic, we straightway go for PSMA PET-CT. Don't waste any money on any other investigation. If that facility is available in India, PSMA PET-CT is available at a very reasonable cost now, 10 or 12,000 rupees only, or even less than that. So that give us the total information, lymph node, bones, local staging also. There is no need to do a bone scan or CT scan or something like that.
Right. Professor Tungakar, would you like to comment anything on this?
Yes,
on
just a
point?
small comment. First of all, that I agree with Dr. Gupta, sir, that whenever you're suspecting a disease that is locally advanced or metastatic, there is no question of doing any MRI. The aim of MRI is to find out high-grade areas or the high-risk prostate cancer. And that is why whenever there is a suspicion of prostate cancer, or you feel that it's going to be a clinically localized prostate cancer, localized to prostate, I would do a MRI. Basically, that because when you're doing a biopsy, you should not miss the areas which have been seen on that MRI. Because if you do biopsies from somewhere else and miss these areas, you may get just a diagnosis of low-risk prostate cancer where it will be treated differently. So the idea is not to miss this high-risk prostate cancer areas. So there it will be of use to you. And for local staging, I think it's very important. That's the best local staging that you can get. And once you have done a biopsy, then all that gets vitiated because of the hematomas and inflammation and infection. So the best time to do it is do it before the biopsy, and then you'll get adequate staging information.
That's a point again. Thank you very much. And shall I move to our next speaker, Dr. Which we have actually left about risk distribution and prostate biopsy. Professor Amlesh Sheikh, he is the professor and head of urology in All India Medical Institute. May I request Professor Amlesh Sheikh to start his lecture and start sharing?
Thank you. Thank you. You have to take your okay.
Jangir, please stop share your screen.
Already.
So, can you see my now?
Yes, but still your screen is black. You are here.
Still,
screen is black. I don't know why.
Screen is black.
It says that you are sharing your screen, but it is not showing any slide.
Amlesh, you first open your presentation, then you share the screen.
I opened.
You can see your presentation.
Presentation in advance, then shared these. Can you see my presentation now? Can you see it?
No.
Unfortunately, not. You open your presentation, but not in a.
Amlesh, you can call somebody from your computer facility to help you. If you are in the hospital.
Now can it be?
Yes.
Now same. Now same. Okay. So thank you very much. So I begin the story of a 63-year-old man who had a PSA of 4.5 and on annual screening, and he got worried. He went to Dr. Ganesh Bakshi. Dr. Ganesh Bakshi did all his PHI, 4K, etc., etc. He convinced him for a biopsy. The biopsy was done, and then after that, his son got transferred from Bombay to Delhi, and this patient came to me. And now I have to guide him what is to be done next. So risk stratification is extremely important in clinical decision making, and there are a number of guidelines that are available which help both the patient as well as the clinician in making a decision regarding how to manage this situation. The risk stratification also improves the consistency of practice, and for those who are into clinical trials, it helps in the designing of the clinical trial by precisely defining the inclusion and exclusion criteria, the consistent reporting, and also having a standardized nomenclature by which I can talk to Dr. Ganesh Bakshi and Dr. Ganesh Bakshi can talk to me, and all of us can talk to each other. We know that localized cancer prostate has a complete range of prognosis. There would be some patients who will have a very low malignant potential, and even if they're left untreated, they will not have any morbidity or have any reduction in their life expectancy. And there would be some patients who will be having intermediate disease and they'll be curable with a single modality, either by a radical prostatectomy or by radical radiotherapy. Whereas there will be some patients who will have very aggressive disease, where after a radical prostatectomy, they may have local recurrence, they may have metastasis, and they'll progress on to metastatic disease and die of the disease. So this last category has been classified as high-risk disease. And we also know, because that these patients are generally elderly in their 60s, 70s, or late 50s, they have other comorbidities and they can die from other causes. And we know that cancer prostate progresses slowly from one stage to the next stage, and then there can be a death in patients who have metastatic disease, which may be hormone sensitive or hormone refractory. And therefore, because of this double situation of a prolonged history of cancer prostate and other comorbidities in the patient, whenever we have to make a clinical decision in the risk stratification factors, we have to take not only the risk from the cancer, but also the risk of death from other illnesses. So it has to be a very complex kind of a modeling which is required. The standard way of most cancers being risk stratified is what is known as TNM staging. This is what we use for cancer of the kidney, we use for cancer of the bladder, we use cancer of the breast, stomach cancer, colon cancer, for all cancers. But in cancer of the prostate, when we have risk, when we have screened these patients and diagnosed these patients and diagnosed all of them are practically in stage T1C disease. And T1C disease is a disease which is diagnosed basically because of PSA screening or 4K screening or whatever screening, and then a biopsy has come positive. And now we have to decide what kind of a modality to advise to this patient. And the most important thing is the Gleason's pattern. I am not going to talk anything further regarding the Gleason pattern because Dr. Santosh Menon is going to talk in detail regarding the Gleason score and the significance of Gleason score. Although this remains the most important factor. And we know that apart from the tumor stage and the Gleason score, the baseline PSA is also very important. And the percentage involvement of the body. A formula was given by Dr. Roach, where he said that the prediction of extracapillary extension can be calculated by this mathematical formula, and seminal vesicle invasion can be calculated by this formula. And lymph node, but this was accuracies. Then from Howard, Dr. D. Amico came out with this risk groups, and this is also known as D. Amico's risk classification or Howard classification. Here you can see that patients who have any of these, even a single one, whether it is T2C disease, Gleason 8 or more, or PSA more than 20, any one of these three is the patient is high risk. Whereas if a patient satisfies all the three conditions of having T1 or T2A disease and Gleason of 6 or less and PSA of less than 10, then the patient is in low risk. Whereas all other patients will be classified as intermediate risk disease. But we know that these three categories are relatively overlapping categories. And although there is a broad risk of less than 25% of progression of the disease in low risk and a very high risk in the highest risk group, but this is actually the main thing that is predicted is the PSA failure. And PSA failure, although it is taken as a predictor of mortality, but it is not absolutely true. And therefore, these are the limitations of the D. Amico's risk stratification. And the NCCN actually expanded these three risk groups into 5 risk groups. And they had very low risk group, low risk, intermediate, high risk, and very high risk. So with this, the predictability of the risk stratification improved from D. Amico's classification, but still it is not extremely useful. EAU has something which is similar to D. Amico's, and it is much more commonly used in Europe. Then Epstein came out with the definition of a very low risk cancer. A very low risk cancer will not progress. For this, all these criteria had to be satisfied, which meant that the PSA density had to be less than 0.1. The Gleason score had to be maximum up to 6. Number of positive cores had to be less than 3, which means 2. And tumor in each had to be less than 50%, and tumor clinically had to be confined to the prostate. So this was the definition of a very low risk, but it did not cover the other ones. So now how to go about it? What I'll tell you what I do in my practice, and I would advocate that very strongly. I was a visitor to MSKCC, and this is what I saw there, but this is in the public domain. It is available for each and every person. It is actually meant for patient guidance, but I can tell you it is very good for physician guidance. I use it practically every time, all the days in my life. So on the website of MSKCC, you have these prostate cancer nomograms. These nomograms can be a pre-radical prostatectomy nomogram, it can be a post-radical prostatectomy nomogram, or it can be for decision making regarding salvage radiotherapy. It can also predict the risk of dying. So there are separate nomograms. This risk of dying due to prostate cancer in a patient who has a rising PSA after radical prostatectomy. And this is a risk of high-grade cancer on prostate biopsy. This you can actually, this is something which was part of Dr. Ganesh Bakshi's talk. He used a different nomogram, and here this is a different nomogram. And there are additional tools, which is the male life expectancy tool. I find this tool very useful. What has been done in this tool is that there is an amalgamation of the pre-prostatectomy risk assessment along with the life tables that are provided by the life insurance companies. The life insurance companies, they predict the life expectancy based on whether you have diabetes or not, whether you have had a stroke or not, whether you have coronary artery disease or not, etc., etc. And those life expectancy tables are very detailed tables. And if you combine these two, the MSKCC website provides you a male life expectancy tool. I'll talk a little more in detail regarding these. So how to use the pre-radical prostatectomy tool? You first have to find out whether the patient has had any hormonal therapy or not, and then you have to fill in whether the patient has had any radiation therapy or not. And then after that, what is the patient's exact age? What is the patient's exact PSA? What is the primary pattern? What is the secondary pattern? What is the total score? And what is the exact clinical stage? Then after that, you get the risk calculation. I'll just show you with a practical example. Okay, this same 63 years old man, he has not had any radiotherapy, he has not had any hormonal therapy, and his age is 63, his PSA is 4.5, his Gleason pattern is, primary pattern is 3, his Gleason secondary pattern is 4, his total Gleason score is 7, his tumor stage is T1C. Only 2 of his scores are positive out of the total of 12, giving a 14.29% of scores being positive. So when I click on calculate, the calculate will give me this. You look at this. There is a 99% chance of cure with radical prostatectomy at 10 years and 15 years. There is a 79% chance that this would be an organ confined disease. There is a 20% chance that there would be an extracapsular extension. There is a 2% chance that there would be a lymph node involvement, and there would be a 1% chance that there would be a seminal vesicle invasion. Now, let us look at the same patient in the post-radical prostatectomy situation. Now, this patient has undergone radical prostatectomy, and he has come back to you at 3 months of follow-up. And his PSA preoperatively we knew was 4.5, age of 63. He has come down 3 months down the line. His Gleason pattern of 3, prime secondary pattern of 4, total score of 7. Now we have the histopathology. And supposing in the radical prostatectomy specimen, we found a little bit of extracapsular extension, and the surgical margin was negative. He has had a complete removal, but a little bit of extracapsular extension. All the lymph nodes were negative, and all the seminal vesicle was normal. And let us see what his post-op situation is, post-prostatectomy situation is. He again has a 15-year, 99% chance of survival due to cancer, but his recurrence-free survival rate has come down because of the extracapsular extension. His recurrence-free probability at 2 years has come down to 95%, and at 10 years has come down to 76%, which means he has a 24% chance of having a recurrence at 10 years because of this extracapsular extension. So now let us see how this tool works for the salvage radiation therapy. In salvage radiation therapy, let us see that this man who had a pre-operative PSA of 21 nanogram per ml and his primary pattern was 4 and secondary pattern was 5. He had a very high Gleason score of 9, but his radical prostatectomy was very effective. He had only a marginal extracapsular extension and his surgical margins were negative. No seminal vesicle involvement, no lymph node involvement, and at the end of 3 months, his PSA came down to 0. Excellent surgery. But slowly, over 9 months, his PSA went up to 0.6, and another 9 months down the line, his PSA went up to 1.2. So his Gleason's disease is bad, and he has had an early recurrence. Now we have to see whether in this early recurrence, whether he is going to benefit with salvage radiotherapy or not. So let us see what are the chances. So he has a 24%. He has a 24% chance of his disease remaining under control at 6 years with radiotherapy alone. So which means that he has a 76% chance that he will need additional therapy over the next 5 years. Okay, so this can tell us regarding the efficacy of radiotherapy and the need for an additional therapy. Now, male life expectancy tool. This is also something which I find very useful. So this same 63-year-old man who had a T1C disease, which was with a PSA of only 4.5 and a Gleason grade of 3+4. Again, a very low to intermediate risk. Actually, this will be classified as intermediate risk disease because of Gleason secondary pattern of 4. So look at this. What are the results? This 63-year-old man, he has a 16% chance of dying of other causes. He's absolutely healthy. He has no hypertension, no diabetes, no coronary artery disease. He's running around, and despite that, at the age of 63 years, he has a 16% chance of dying of other causes. He has a 28% chance of dying of other causes at 15 years. And he has an additional 6% chance of dying of prostate cancer if this cancer is not treated. So with treatment, he reduces his chance of dying because of prostate cancer by 6% at 10 years and by 13% at 15 years. So let us go next. Next. Now the same 63-year-old man, supposing he has all the comorbidities in the world. He has angina, he has blocked arteries, he has congestive cardiac failure, he has diabetes, and he has high cholesterol. So this same 63-year-old man with a lower risk cancer of Gleason 7, PSA 4.5, has a 68% chance of dying because of other causes within 10 years, and only additional 2% chance of dying because of prostate cancer. And at 15 years, his chance of dying, irrespective of prostate cancer, is 84%, which goes up to 88% with prostate cancer. Now let us go up. Here you can even have a selective only diabetes, only hypertension, only stroke, or only coronary artery disease. And therefore, then you can get a more precise idea whether what is the chance of the patient dying irrespective of the prostate cancer and what is the chance of the patient dying because of the prostate cancer. So now, this is another 78-year-old man. Now the age has gone up to 78, but he has a low-grade cancer and he has multiple comorbidities. If he has multiple comorbidities at the age of 78, he has 86% chance of dying prostate cancer.
Excuse me, Dr. Amalesh said, Professor Amalesh, we cannot hear you.
কিন্তু তুমি দেখি দেখছো না এটা ভালো
ভালো আসল কোনো ব্যবহৃত
তাহলে আমরা তিন দিন করে লই
Dr. Jahangir, we can proceed further.
যদি এয়ারপোর্ট দিন ঠিক না
Shall we leave him, sir?
Yes, yes.
All right, now, all right, sorry.
করে দিলে এটা তো 4 দিন পর বললে ভাইরাস থাকবে
Yeah.
No, he can join us at the last point.
Right, we can bring him in the discussion.
Yes,
Not
he can
discuss
join
We're
the
running out of
later.
running little late, so can I invite next speaker, Dr. Dr. Santosh Menon, Professor of Geopathology, Tata Memorial Hospital, Mumbai, for his lecture of different grade and or group what urologist wants.
Hello.
Sorry, Professor Sheikh, we have to leave you because we cannot hear you and we are running out of time. So may I request Dr. Menon?
Thank you, Dr. Jahangir. Am I audible?
Yes, you are audible. Fine.
So can I start sharing my screen?
Yes, please.
Yeah, but Dr. Amlesh will have to stop sharing his screen, I think.
Exactly. I don't know how to do now.
One can call him and tell him stop sharing.
I've already.
He has stopped sharing. Can you?
Yeah, I'll try.
Can you?
Oh, I cannot still say because the other participant is sharing, it says.
Right.
Dr. Jahangir, as the host, you can try to put your screen, then I'll try then, maybe. I don't think that's also possible.
Host can do it. Shua Datta, who is the host?
We are trying, but there is some problem.
Okay. Otherwise, only host has control, other than the speaker.
জাহাঙ্গীর ভাই সিরাজকে বলেন ইউনিমেডের সিরাজ সাহেবকে বলেন
Can you call Dr. Menon to stop his sharing? Menon.
I can make a call. I can make a phone call to Amresh.
Yes, I'm just trying, sir. I'm just give a call.
Hello.
You are in here?
So now we stop sharing. Huh?
Professor Santosh, can you stop sharing your screen?
I'm so sorry. I was trying to call him, but his phone is switched off.
All right. Okay. Thanks. Oh, sorry. All right.
Anyway,
No, sorry.
Dr. Amalesh, when he will be coming back, he can discuss the rest of the slides as a last speaker. Dr. Jangir.
Yes, yes, you can start sharing now. Have you talked to him? Sir?
Amresh's phone is switched off. I don't know. I tried to call him, but his phone is switched off. Host can do something for us.
I think till the time you can at least take a couple of questions.
Yes, sir.
Yes, please.
Questions?
Now, even then,
I just wanted to know from Dr. Gupta, who's probably got one of the largest experience in prostate cancer in the country, whether he routinely uses these nomograms.
No, actually, you can say I'm not using a particular nomogram, but for our radical prostatectomy cases, that prostate risk calculator, that for pre-radical prostatectomy, certainly, because we have to tell the patient what is the likelihood and what is going to happen to him. I think so. This is very important for counseling point of view. Otherwise, we use our same parameters and use our clinical judgment, and we tell the patient very frankly, actually, and I always tell in high-risk patients especially that one treatment may not be enough and patient will need multimodality treatment.
Right.
Yeah, okay.
Patient counseling.
we got Shantan Menon on the screen, so we start hearing him. Yes, please, Dr. Santosh. Can you start
thank you,
your
Dr.
talk? At last we got it.
Jangir, and thank you.
Sorry, we are behind the time. Sorry.
Thank Dr. Salam and Dr. Shafi for having me here in this teaching program. So my topic is on Gleason grade and how things have changed evolved over last few years regarding this. So like typically spoken in previous talks, you have a elderly male coming up with lower urinary tract symptoms who has got an enlarged prostate, and DRE is this. So this is the common scenario. You have to put your finger and do a digital rectal examination as a urologist. And if the DRE and PSA are suspicious, then you ask for a prostate biopsy and immediately ask for a prostate biopsy if the PSA is raised and the DRE is suspicious. Am I audible?
Yes.
Okay.
Absolutely.
So basically, the diagnosis of prostate cancer is based on DRE, serum PSA, and if required, a biopsy. If you look at serum PSA, the approximate chances of having prostate cancer on a biopsy is, if it is less than 4, it is 1 in 50, whereas if it is greater than 10, then 1 in 2 or 2 in 3 patients of prostate cancer would have a positive biopsy. There were studies, this is a study which says that if you do only PSA, 18% would be missed, and if you do a DRE alone, 45% of prostate cancer would be missed. And hence there is a need to do prostate biopsy to confirm and categorically say that this patient has got prostate cancer. So just to say that the prostate cancer is mostly arises in the peripheral zone, and so the biopsy is directed to the peripheral zones of prostate. Mainly in the peripheral zones you find prostate cancer. And one thing which is important is that prostate cancer is many times multifocal. Most of the times it is multifocal, in fact. So you may have a tumor sitting on towards the base of the bladder. You may have tumor at the apex of the prostate. You may have tumor in the lateral part of the prostate in the peripheral zones. So that's the reason that we do 12 core biopsies. So this is our own picture from TMH, where we have these 12 bottles, 12 containers in which you have 12 guided template core biopsies from 12 different areas of the prostate. We diagnose under the microscope when we see these small looking glands. Within these larger glands, then we start suspecting prostate cancer. The other thing is presence of this mucin, fibroplasia, perineuralism. This is a nerve bundle which you can see here, and this is a tumorous gland which is around the nerve bundle. So these are features to prick prostate cancer. And sometimes we resort to immunohistochemistry with basal marker negativity. In the malignant glands, there is negative basal markers and positivity for AMACAR. So I'll come to Gleason grading directly. In 1966-67, Sir Donald Gleason based his grading. He made these diagrams, these beautiful hand-drawn diagrams. While looking at the cancer under the microscope, he predicted, he grouped them in various patterns and said that as and how the tumor glands separate out, that means the tumor glands, the glandular formations become less. They become more fused, they become more single. The chances of those becoming more malignant and more prognostically bad with poorer outcome is seen. So this is how he, under the microscope with astute observation, he made these diagrams and came up with the Gleason scoring. So why is it important? Why do the clinicians, why do the pathologists really have to break their neck heads over Gleason grading? What does it convey to the clinician? It influences planning. It predicts pathologic stage, extra prostate extension, seminal vesicle invasion. So in a biopsy, if you have some scoring, you can really predict with the help of nomogram, which has been very elaborately taught by Dr. Amlesh sir. So this is one of the most powerful prognosticator. And in NCCN guidelines, I think the 2020 version is also in every category of risk group, from very low to very high. You see in every category there is a Gleason score or a Gleason grade. So we'll be coming to that. And this is important because based on the Gleason score and the number of cores involved, the therapeutic options vary from active surveillance to surgery to radiation and hormone therapy. In 2005, they modified the Gleason, and some of the fused glands which were, or papillary glands which were in pattern 3 were made to go into pattern 4. So that's the important change which happened in 2005. So pattern 3 only had separate looking glands. So each of these structures which you see are separate glands. As long as the glands are separate, we call it pattern 3. Once the glands start fusing, once they have this cribriform punched out, this kind of Swiss cheese kind of appearance, then we call them pattern 4. So that was modified in, this is what the modification said in 2005. Some issues. So this is just to, so suppose this is a core. This is a core which you sent to us, and as a pathologist, I see 60% pattern 3, 25% pattern 4, and 15% of the tumor has pattern 5. So what original Gleason would have called it a 3+4/7. That's original means the 1966 classification of Gleason would have called it a 3+4 Gleason score. But after the 2005, it was recognized that even this minute quantity of pattern 5 has to be included in the Gleason scoring. So that's the major change which happened in 2005. So in 2000, after 2005, what we do now is we take the first pattern as the commonest or the most predominant pattern, and the second in the score as the most highest score pattern. So that's the basic modification which has happened in 2005. This should be very clearly understood by everybody. The problem with the original Gleason system was that you can have all these scores, 1+1 2, 1+2 3, which were never actually seen in clinical practice. So in a core biopsy, the least which a pathologist can convey to the clinician is a score of 6. So anything under a score of 6 on a core biopsy should not be acceptable by the urologist, because the minimum score which can be picked up on a biopsy is actually a score 6 Gleason prostate cancer. The combinations gave a lot of issues in Gleason system. The other understanding is if you tell the patient that you have a Gleason 6 cancer, the patient will think, oh God, I have got a 6 out of 10 score cancer, so I'm somewhere in the middle of the spectrum. That means if I have to be treated urgently. But in actual clinical parlance and clinical practice, what you see is a Gleason 6 cancer is the lowest grade of cancer which you actually see. So it is at the lowest end of the spectrum. And this was a big thought and understanding of prostate cancer. So there have been certain other basic observations. There was a paper in 2012 from John Hopkins, which said that Gleason score 6, less than Gleason score 6 tumors on prostatectomies have a metastatic potential is almost 0. So a pure Gleason 6 cancer will not metastasize to the node, will not metastasize and kill the patient. So that's what I understand. The other corollary of this is a Gleason pattern 4 has to be seen under the microscope for you to and us to start thinking that this patient has a metastatic potential. So that's the understanding which has come. So there was a need to develop a new grading system to prognosticate the patient with this new understanding that a 6 score cancer is the lowest grade cancer that will not metastasize, that will not kill the patient. Whereas anytime you start seeing pattern 4 under the microscope, that's when you have to prognosticate the patient better. So in 2014, they came up with this new Gleason grading grade group system. This was validated on 20,845 patients across 5 institutions. So this is the new grade group system. So what they have done, they've called now grade Gleason score 6 as grade group 1. And why is this? This is because it's a patient friendly. You can tell the patient that you are at the lowest grade group. You are at grade group 1 and you may not need treatment, and active surveillance may be enough for you. So that was the reason of putting this as grade group 1 because this is a lower grade. And many studies have shown that a 3+4 cancer and a 4+3 cancer have definite prognosis. A lot of Kaplan-Meier curves, I'll show you some, which basically had made them split 7 into a grade group 2 and grade group 3. any score of 8, any combination score of 8 would be put in grade group 4, and any score of 9 and 10, 4 plus 5 or 5 plus 4, 9 would, and 5 plus 5, 10 would go to grade group 5. So why are these groups? What are these groups? Are these really relevant in clinical practice? Is it useful? So this paper shows that these are actually prognostic grade groups, and this Kaplan-Meier score curve shows you that these grade groups have got different outcomes as far as biochemical recurrence-free survival is concerned, as well as probable recurrence-free progression. So grade group 1 has got the best. Grade group 2, which is 3 plus 4, is better than 4 plus 3. So that this understanding has better prognosticates the patient, and that's why we have started using a grade group system. It's more patient friendly. It is more clinically relevant and more outcome measurable. So if you have different cores in 12 bottles, in 12 containers, how do you start giving the group? So supposing these are your 12 slides, which we see under the microscope, and every core is separately scored and separately grade group, and maybe separately grade group, but the final score, so there is one core which is showing 3 plus 5, 8, which is grade group 4, and that's would be taken by the urologist for clinical decision making for the risk stratification. So that should be understood. This is another example. So you have many cores, many slides which show 3 plus 3, 6 cancer, but then there are a couple of cores which are 4 plus 4, 8 cancer. So the final actual maximum Gleason score for this patient would be put up as Gleason 4 plus 4, 8. So the benefits of the new grade group, it's more simplified. Lowest grade group is 1, which makes the patient also understand his disease better, and it has been accepted by the 2016 WHO. I think I'll quickly skip these for the bit of time. Another important thing, in a 3 plus 4 cancer, you need to give the percentage of pattern 4. So you have a 3 which is predominant and a 4. So is it 5%? Is it 10% of the total Gleason score? That we have to put it in our report, because that's prognostically important. So I think this is the most important slide as far as urologist is concerned. When should you question your pathologist? So you get a report of prostate biopsy report, and so you should question. When do you question? So when there is a question of putting the patient in active surveillance versus a radical prostatectomy, the score 6 versus score 7, you have to be 100% sure you're dealing with a very, very lower end or grade group 1 cancer. So grade group 1 should be made sacrosanct, because those patients can be offered some kind of active surveillance unless until they're all their core biopsies, or 12 out of 12 is positive, or 5 out of 6, 5 out of 10 are positive. The other thing is lower grade group, and grade group 1 and 2. Again, in grade group 2, that is 3 plus 4, the percentage of pattern 4. Supposing you have 2 cores and one of the core is showing 3 plus 4, 7, but very little percentage of pattern 4 in the core, that patient may also be a candidate for active surveillance, and that's important for you to understand. You should question your pathologist whether he's sure about it. And next, in a metastatic setting, if your pathologist has reported that all cores are showing 3 plus 3, 6 cancers, he's probably made a mistake. There is a theoretical possibility that he has missed a 4 or the biopsy has missed a 4, but all in all possibility is a 3 plus 3 cancer does not metastasize, does not go to the node. So that should be the basic understanding in prostate. So this is a model prostate biopsy report. You need the type of cancer, the Gleason score, the grade grouping, number of involved cores, percentage of core involved by cancer. If there is 3 plus 4 score or 4 plus 3 score, the percentage of pattern 4 is important, and extra prostatic extension, if seen on a core, should be reported by the pathologist. So just to conclude quickly, I think in medicine in the maths, 3 plus 3 we call it grade group 1, 3 plus 4 we call grade 2, 3 plus 4, 4 plus 3 we call 3, and so on and so forth. So I think we have a medical oncologist, a medical oncologist, radiation, as well as a surgeon who are treating. But somewhere behind the microscope, we do an important job as a pathologist to prognosticate the patient. And this grade grouping system has really brought us to the forefront in this. I would like to acknowledge my DMG colleagues, Dr. Bakshi, and all my residents. Thank you very much.
Right, Dr. Santosh Menon, this is an excellent delivery, and it's enjoyable to listen. And we have enjoyed your topics. For the whole topics, you kept us amazing. So, I mean, may I proceed to our next speaker, because we are running out of time, so we can discuss the whole thing at the end of the, because our next speaker is Dr. Palak Popat, and she will be talking on multiparametric MRI and role of local staging. And after finishing our talk, we will get comments from our on the honorable panelists, as well as any question and answer. If you bear with us, we can ask you some questions, and then we can get a comment from our chairman of the session, Professor Salam. So may I request Dr. Pollard, I apologize for delay and other things, you can understand. So bear with us for some time more, and please start your lecture. Thank you.
Yeah, good evening, Dr. Jahangir. Thank you for the kind introduction. I will just share my screen. Is my PPT seen?
No, not yet.
Not
Is
yet.
my PPT seen?
No.
Okay, my PPT is open.
After opening, you share
Is
a
it seen
screen.
now?
Yeah, it will be seen. Yeah. Yes.
Yes.
See?
You
Okay,
can
all right,
see.
fine, thank you. Right, so very good evening, everyone. I'm a radiologist. I love the picture that Dr. Santosh had shown of all the specialties. So yeah, I'm here to talk about the role in local staging of multi-parametric MRI of the prostate. So the point is, why are we doing this? So basically, it is an MRI, right, of the prostate, using specific protocols and sequences to improve the detection and staging of prostate cancer. It's not moving slide. Okay, yeah. So basically, the whole fundamental of MRI has now changed from doing a gross overview MRI of the prostate to something which is more specific, where we now want to see the clinically significant cancers versus all cancers. So the average specificity is 0.88 and sensitivity of 0.74 of a multi-parametric MRI, and the negative predictive value ranges from 0.65 to 0.94. It's a higher range. Now, where would you refer your patients? So as per the guidelines, the validation is only for 1.5 and 3 Tesla, because we need a good high resolution for prostate. So a lower strength MRI does not serve a very good purpose. Do we need an endorectal coil? It becomes very expensive and very uncomfortable. So what happens is the patient moves, and then we will get artifacts, and then so sometimes even with that coil, we don't get very good images, and the cost is very high. So it's not really recommendable. And now with the dedicated sequences and protocol, the resolution is fairly comparable between the two. Patient preparation. So Ascopan, sometimes patients say, but we don't really need, because prostate is way down, so the bowel artifacts do not cause much of an issue. However, if the patient is constipated, then you can generally give some laxatives, maybe a day prior, so that there are not many fecally loaded artifacts going from the rectum into the prostate. So what do I mean by saying multi-parametric MR? It is multiple parameters. And what are the parameters I'm talking about? There are various sequences like T2, diffusion, post-contrast sequencing, spectro, T1 weighted, and there is something called as a large view, a large picture to see the lymph nodes. But when we talk of evolution from the basic MRI towards a dedicated PIRADS, is what somebody mentioned even earlier. I will come to what PIRADS is, but the difference is there are many sequences here, and there are only 3 specific sequences which are required for PIRADS, which would be a smaller view of diffusion, of T2 weighting, and post-contrast only when I need to solve a doubt. So currently the use, if I look at an overall broad picture of multi-parametric MRI, it would be for tumor detection. So is there something in the prostate? Where is it localized, characterized, benign or malignant? Risk stratification. What do I feel about it? Surveillance. If you feel it's not a very suspicious lesion, you can put the patient on active surveillance. It is good to see it change over time. And image guidance as a route for biopsy, surgery, or focal therapy, and radiation therapy. So there are many uses when I talk of a multi-parametric MRI. But when I talk of PIRADS, it is a very focused perspective. So when we talk of a multi-parametric MRI, how does the prostate look? So let us look at the prostate with a small picture. I have the bladder anteriorly, This is the rectum posteriorly, and I have my pubic bones here and the femoral head over here. So you have a rough idea. So we look at the prostate, where we have a peripheral zone and a central region, which is called as a transition zone. So this is a pictorial representation. If I try to overlay it, we have the peripheral zone on the two sides with an anterior and a posterior part. The central region has basically, it comprises of the transition zone, which is the anterior and the posterior. Of course, you all know the zones perhaps much better than me, but what I want to show is where these zones are located on an MRI. The two darker areas here are the anterior fibromuscular stroma, and this is the base of the prostate. So at the top, what we see posteromedially is the central zone, and we see the ejaculatory duct opening right out here. Similarly, at the mid-level of the prostate, we have all the same zones except that the central zone is now replaced by the part of the peripheral zone, which is now called as the posterior and medial. So posteromedial peripheral zone, and these are the posterolateral peripheral zone, and this is the anterior peripheral zone. Transition and AFMS. And similarly at the in the apex of the prostate. So coming to PIRADS, now I gave you the multiple uses of our MR prostate, but PIRADS is basically to determine the clinically significant cancer on MRI. It is not about lymph nodes, it is not about other things, it is only about the prostate and something which is clinically significant, not an occult prostatic cancer, which is not going to be significant, or a lower grade cancer. The objective is basically to improve the outcome for patients and avoiding unnecessary surgeries and treatments for the low-grade cancers. So the version 2 has a very specific definition of improve the acquisition. So we have better technique of taking the scan, detection to find, localize, characterize, and risk stratify in suspected cancer in treatment naive prostate gland. So if somebody has undergone a surgery and then the surgery, the histopathology report is already there, or maybe a BPH surgery was done, that patient is not treatment naive. So PIRADS version 2 does not really stratify these patients. So there are certain aims which we have kind of seen, so I would skip that. What are the categories that you see in a radiologist's report? So they would say PIRADS 1, PIRADS 2, up to 5. So 1 is when, I want you to remember that 1 does not mean it is normal and there is no cancer. 1 means that clinically significant disease is highly unlikely to be present. So there may be a cancer, but probably a low grade, you're not worried about it. Score 2 is when it is unlikely. Score 3 is it is equivocal. 4, it is likely, and 5, it is highly likely to be present. So what do we do? As I said, in PIRADS, you're looking at 3 sequences, the diffusion, the T2, and an SOS contrast sequence. So now diffusion, there are certain features that we as radiologists see, which would be present predominantly in the peripheral zone, and sometimes we use it in the centrally placed transition zone. So on my diffusion, if my peripheral score in my peripheral zone, I look at a lesion and I say whether it is 1, 2, 3, or 5 based on how it appears on diffusion. So that will determine my PIRADS scoring. When I look at the transition zone, my PIRADS scoring will be determined on the T2 weighted image, because there are specific morphology of a T2 in the transition zone, diffusion in the peripheral zone. So it matters how it looks, and that is what is going to form my final scoring system. So here's a flow chart where I start from the peripheral zone and I look at the diffusion sequences, and based on what it looks like, I will call it a score 1, 2, 3, 4, or 5. 1 and 2, I'm not worried. 4 and 5, I know it's a malignancy. The difference between 4 and 5 is not that 4 is less likely or likely, more likely. 4 is anything which is more less than 1.5, but you're quite certain this is going to be a significant cancer. 5 is also you are quite certain it will be a significant cancer, but it is more than 1.5 centimeters in size, or it is spreading outside and it has extra prostatic extension. But when I have a 3, I'm not really sure. So to help me, I will look at the contrast images. If my contrast images tell me that this is likely to be a cancer, I will upgrade it to a 4. And I will say this is more suspicious, PIRADS 4. If my contrast is not supportive, it doesn't become a 2, it remains a score of a PIRADS 3. Similarly, then when I come into the inner side of the prostate, I start looking at the transition zone. And in the transition zone, I look at various scores of the T2 weighted image, whether 1, 2, 3, 4, 5. When I come to a score of 3 and I'm not sure, I do not take the help of a contrast. I take the help of diffusion. And it tells me whether prostate cancer is likely or not likely. So now there is a certain ideal report that is required. And if you do not have these, you could probably check with your radiologist and get them added if it adds value to you. So a volume and a PSA density is optional. Anatomical mapping of the lesion is essential. Assigning PIRADS if the patient is treatment naive. Staging disease in terms of extracapsular extension, neurovascular bundle, seminal vesicle invasion. All this is very well seen and it must be put in your report. Adenopathy, bone metastasis, and incidental findings. So how does a lesion look at on T2, as I said? So something which is very nicely well circumscribed around the focal lesion. This is going to be a suspicious lesion. This is in the peripheral zone, and this is called, this would be a PIRADS 5. But it is less than 1.5, so I will call it a PIRADS 4 lesion. Another T2 morphology. So that was a T2A lesion less than half. This is a larger lesion, and this is going to be almost half of one side of the prostate gland. The next is a T3 lesion, where this is a peripheral zone of the prostate, and there is an extracapsular bulge, and it is probably almost encasing the neurovascular bundle also. And then after, I'm sorry, I will have to take this call. Please pardon me. I'm extremely sorry for that. I just had to take that call. So I was talking of T3B lesion. So this is when I have tumor which is obviously invading the seminal vesicles. We have the bladder here. Am I audible? Am I audible?
Yes, very much. Clear.
Sure. Thank you. Sorry for the disturbance. So when I have tumor invading the seminal vesicles, so this is T3B, we see the vesicles very nicely like a bunch of grapes sitting out here, and then there is this altered signal intensity tumor. I know this is disease. We see the disease extending from the prostate all the way up here to the seminal vesicles, and then this is very obvious. So we know that we are dealing with a T3B lesion. This is a T4 lesion where the prostate is infiltrating anteriorly into the bladder wall is gone. Also, there is an interluminal extension present over here in this slide. And here also we have extensive disease. So this would be a T4 lesion. So talking of diffusion, how diffusion helps, is a prostate, and we have a very dark area over here in the peripheral part. So usually tumors are darker or more blacker than the normal prostate, which radiologists write as hypo-intense. Hypo means they are less bright, so they're darker. So this is a diffusion sequence. They're usually the most dirty and shabby sequences that you cannot interpret anything that has got to be diffusion. So in a diffusion sequence, I see a brighter area corresponding to the darkness seen earlier. This means that there is a tumor sitting out there, but I have to confirm on another sequence called as the ADC. And the ADC shows me a black area, which means that yes, this is restriction of disease, and hence this is a tumor sitting out here. And I'm pretty certain I will call this a PIRADS 5. It looks more than 1.5 centimeters. This is how dynamic post-contrast images would help. So this is a T2 section where we see a lot of dark areas over here in the central region, some in the peripheral region. And then on diffusion, we have a lot of dark areas here. This is the ADC. On the ADC, the tumor should look blacker. So I have tumor here. I have the tumor here, here, and probably some tumor over here on the sides also. So this in this case, I would not need a dynamic post-contrast, but our students had already done a dynamic post-contrast meanwhile. And this is how sequentially we see the enhancement of the prostate. There is a lot of heterogeneous early enhancement over here. This is extension to the seminal vesicle on the top, very nicely seen on the contrast images. And this is a delayed image where you see there is detention of contrast here, here, and there is washout. There is washout of the contrast. Washout means it now looks darker. It looks darker, and look at the area over here in the seminal vesicles. Again, this is darker than before. This is washing off. So a rapid rise in is more important of contrast to say that yes, this is positive. Coming to spectroscopy. So what is spectroscopy? So there are certain chemicals in the body, and the titer of these chemicals depend on how much they there is a peaking which happens because of resonation of these tiny particles. So more the quantity of it, greater is the peak. That is a very basic thing about spectroscopy. It is a spectrum that we see. So normally in the prostate tissue, we have high amounts of citrate, and they are higher in the peripheral zone. We have certain ratios of choline is to creatinine and citrate. So whenever there is a malignancy, the cell walls have choline within. So a malignancy deals with higher level of choline, and a normal prostate will have higher levels of citrate. So it is a common thing. Normal prostate has high citrate. The moment we deal with a malignancy, functioning is gone down, so citrate drops. And because of malignant cells, choline starts increasing. So it is a reversal of ratio that tells you that there might be a cancer that you may be dealing with. So there are certain average ratios that we look at, and there are articles where the ratio does correlate with the Gleason grade, hence it can be used to determine aggressiveness. But every machine has a different form of spectroscopy generated. So spectroscopy is not standardized as much across all machines, across different Tesla. Hence, this is not a part of PIRADS version 2. So it still remains more on the research or a problem-solving tool of a patient. So for example, over here, I'm not sure what is this. There is a big, large nodule. These are obvious changes of BPH, but something like this in the central region, I would be worried. It is very large and it is not classically bubbly like a BPH. But the spectroscopy gave a very nice citrate peak. So this would have been a BPH nodule. This is another patient where patient has undergone surgery and the peripheral zone is totally dark with a lot of extracapsular extension. We don't know whether this is fibrosis because of surgery or whether this is disease crossing the capsule, and or whether it is because of prostatitis that there is a lot of inflammation. But very, very high choline level peaks over here suggest that this would be a residual malignancy post-surgery. Here there is a very obvious disease, so we would not need spectroscopy in something like this. This is involving the seminal vesicles, but this was also, it just had a spectroscopy, and this was a very, very high level of choline and very low citrate levels. So this was also a malignancy. The next thing on the MR that we see is the lymph nodes. Lymph nodes, we basically look at the short axis dimension. That's the short axis dimension. If they are round, then even when they're 8 millimeters, they're suspicious. But if we have an oval node, when they're more than 10 millimeters, they're called suspicious. But I think we definitely pick up 5 to 6 millimeter nodes also a lot of times, and they do look suspicious. And yes, they do turn out positive on histopathology also. So I think this criteria, what is usually there in the literature, is not very definitive. So what is the implication? Your radiologist says that it's a PIRADS 4 or a 5. What do you do? It means the likelihood of clinically significant cancer is higher. This patient needs a biopsy. 1, you need not biopsy. If the report says PIRADS 2 or PIRADS 3, then you rely on other criteria for further management, like laboratory, clinical history, local preferences, expertise, and other standards of care. If it is a negative biopsy, but they just said it's a PIRADS 4 or a PIRADS 5, the suspicion is still there. So what do you do? So there's various literature where they have compared MRI-guided, transperineal, and transrectal saturation biopsies. They are fairly comparable, but what was observed that the number of cores that you need for biopsy are lesser when an MRI-guided approach was done. MRI-guided approach does not mean it has to be MRI in gantry biopsy done. It could also be getting an MRI done, imagining where the lesion is, trying to fuse it either with a software or just trying to fuse it with one of your cognitive method or a software, and that tells you whether it is a malignancy or not, and then target that specific lesion. Thank you, and hopefully everybody stays safe.
And I think a lot of people have benefited from this talk. And may I now request our learned panelists to start some discussion on these matters. Last 3 lectures, we could not have any question and answer session. So may I start with Professor Gupta, sir? So just to summarize the things.
Dr. Jahangir.
Yes,
Dr.
sir.
Jahangir, could you please check whether Amalesh Shet is available? He can speak about the
Dr.
last
Salam.
few slides.
Yes, I am here. I am available.
You are connected, sir. Right. Do you want to finish
If
your
he is connected, then he can complete his presentation. Please allow him.
I have already completed my presentation. Anyway, I'll just briefly tell you that there are a number of
You can summarize, Amlesh.
Yeah.
Just summarize your talk. Yeah.
Okay, am I audible now?
Yes.
It was a wonderful presentation. We are learning.
Actually, in the end, what I said was that my favorite is the MSKCC website.
Yes.
And I would encourage everybody to visit that website because it is freely available, and one can actually, any patient can go in, any doctor can go in, any researcher can go in, a person who can also go in. So it's very simple. And there is a separate nomogram for a pre-operative situation. There is a separate nomogram for a post-operative situation. There is a separate nomogram for rising PSA. And there is a separate nomogram for rising PSA in castrate resistance. There is a separate nomogram for the pre-biopsy situation. And the one that I find most useful is the male life expectancy table, which is amalgamated with the pre-operative expectancy, where they take into consideration the comorbidities also. If a person has hypertension, then that is also taken into consideration. If a person has hypertension and coronary artery disease, then that can be taken into consideration. If a person has hypertension, diabetes, and coronary artery disease, all 3 can be taken into consideration. And then one can find out what is that individual's risk of dying because of other medical conditions, and what is the risk of that patient dying because of that specific PSA, that specific stage of the disease, that specific Gleason score, and everything is taken into consideration, and therefore one gets a very precise mathematical prediction of what is likely to happen percentage-wise to that particular.
Right. Finally, we can see you, and it was a very good presentation. Dr. Amalesh, we thank you on behalf of our foundation, and certainly the people will be inducted to see the MSKCC website for this elaborate.
Right, sir. Shall we go to the to get comments from the panelists on the?
Yeah, there are quite a number of people still are hanging, about 52 participants. I hope there are a lot of questions and we can address to that question also.
Yes, sir. There are a few questions from the audience as well. I think panelists and
yes, we can discuss.
Yeah,
panelists are there. I hope Professor Tongaonkar and Professor N.P. Gupta should be congratulated and should be given a news association by our foundation.
There is a question. There are 2 questions here. I mean, is it necessary to biopsy a frail elderly man with a craggy hard prostate,
yes,
PSA greater than 100 nanogram per ml, prior to commencing any palliative hormone therapy? The one. Another one is the patients came with bladder outflow obstructions indicated for TURP, whether it is necessary to do a biopsy if it is suspicious of prostate cancer beforehand, or go for operation directly? There are two questions from a young urologist, Dr. Arafuzzaman. May I ask Professor Gupta to start with this conversation?
I will answer the first question, whether biopsy is necessary in all the cases. In my experience also, I have seen patients like that. If there is a contraindication for biopsy, for example, a very elderly man, 96-year-old or about 90 years, they have on anticoagulants, they have a poor heart condition, and when there is a urinary tract infection and there is a risk of doing the biopsy, risk of complications of the biopsy. And in this situation, more than 100 rectal examination is showing hard prostate, PSA more than 100. And if you have done a bone scan or PSMA, PET-CT showing secondaries, then you have a choice to do the treatment without biopsy. Like emergency, you can say, and we will start the hormonal treatment either way of injections only. We don't like to do orchidectomy on any man without a biopsy report, because orchidectomy cannot be changed. But hormone you can stop any moment. And after the first injection, 3 months, you will see a very good response. And if whenever the general condition of the patient improves or he becomes fit, we prefer to do biopsy for documentation purpose. Because if you are referring this patient to any radiation oncologist or medical oncologist, they will not give any treatment until unless histopathology report is available. So that is the practice followed in our place. But I agree that if somebody is very elderly, then one can avoid the biopsy. But that is only temporarily. Explaining to the patient, taking a consent from the patient, write down on the file that it is on request of the patient, biopsy has not been done. Otherwise, biopsy should be done, because you can miss the neuroendocrine tumor or something like that. So that is the advantage of doing the biopsy.
Right, sir. Professor Tongakar, can I ask you one thing? Sometimes we get patients in a catheterized patient, blood outlet obstruction. In that case, by palpations, the prostate is not malignant. Even if you do the PSA that marginally raised, maybe around 6-7 because of the associated infections, and people want very quick recovery. In that case, should any person go for a TURP without doing a biopsy, or we have to go for a biopsy and then TURP? There's a very hot questions to our young urologist.
I think that would depend on what his risk of prostate cancer is. If it has been after the catheterization, obviously that's going to vitiate the correct reading, and you may get PSA that is raised without actually there being prostate cancer. So in a catheterized patient, PSA by itself doesn't have much of a value. You need to corroborate the PSA findings with the DRE findings, and also if required, you can do an MRI to find out whether there are any likely high-risk areas there. But if there are no such areas in MRI which are suggestive of high-risk prostate cancer, no significant areas there, then I would probably go for a TURP and then do the histopathology. So it's just not only on PSA, but it's also on your other findings that it is dependent.
Professor Salam sir, can you hear me? Can you unmute yourself? Can you unmute?
Yes.
You get a lot of patients like this. I mean, I know that
in this particular cases, so that we can identify or we can understand the possibilities of prostate cancer.
Now, the question is that when you get the patient's histopathology result, it comes out the prostate cancer. So may I ask you how you manage them at that time? What do you do at then? Is there anything change in the management, or if you do something, or is there a potential harm has happened to the patient because of the TURP? As the patient
I used to get a lot of patients like that, but it's not harmful, because after TURP one can go for radical prostatectomy or radiation therapy without any problem, I believe.
Sir, Professor Gupta, sir, or do you want to comment on it?
So what I want to say is that when we started robotic radical prostatectomy in 2006, at that time we used to get a lot of patients on whom a TUR prostate has been done, because that was the practice followed. But today, if somebody asks me this question, will you like to do a biopsy first? And Dr. Tangaonkar has already mentioned that somebody has a retention of urine, you have done a PSA may be high, there may be infection. So better, it is good for you that after control of infection, you do a biopsy. Because once you have a biopsy, then you can plan a proper treatment on that particular patient. If he is a candidate for radical prostatectomy, then why you should do a TUR prostate? I'll ask that question first actually. I will do a MP MRI, see what is the decision for the patient. Otherwise, if I have got I'm just completing please. And then if I have a patient really who has got a biopsy proven locally advanced disease, which is not possible to do a radical prostatectomy, in that situation, I also recommend not only a channeling TURP, I call it a cytoreductive bipolar TURP, in which you can resect up to the prostatic capsule, because all gland don't have a cancer. A lot of portion of the gland may have only BPH, and you can see the capsule. At least I can see, and I am doing that, and I have got a large number of patients whom I have done cytoreductive prostatectomy, and this terminology is not mine. It is already used nowadays in a multimodality treatment. So what my point is that if your new patient has come to you, I think so better you should have a diagnosis, then you do a proper planning of the treatment of that patient instead of jumping for a TURP.
I agree. I think I said the same, that I think MRI needs to be done first. If MRI is clear, then you can go for a TURP.
Right.
Absolutely correct.
Right. Dr. Pollock is with us still. Can I ask you one question? Because there is a question. Can multichromatic MRI replace animal biopsies in patient under active surveillance? I mean, can we follow the patients with multiple MRI in case of patients under active surveillance? Like
established indications. If we feel, see, if I say it is PIRAS 3, 4 or 5 means biopsy. If I say it is a 3, which means that I am suspicious or I'm equivocal, it may not be a malignancy. If I say PIRAS 2 or 3, it means you will look at a clinical parameters. So based on the clinical parameters and my equivocal finding, if it is concordant to put the patient on surveillance, then MRI helps tremendously, because today I have a baseline MRI. 6 months down the lane or whenever the urologist deems that, okay, now we need a follow-up MR, and the lesion has not changed at all, either in terms of size or in terms of the degree of brightness on diffusion, then it can give us some confidence that we can keep the patient on further surveillance. There are some patients with us also who are on surveillance. The lesions are totally the same. They have not changed. And one of the biggest drawbacks or fallacies of a prostate MR is that there is a lot of heterogeneity. Today, patient A's prostate is different, patient B's prostate is different, and there's too much of inflammation and infection in our country. So the point is, the first time you are never that good, but the moment you have a baseline, it's like a finger on a follow-up time. If it is going to change in appearance and you are worrisome in any way, then you know you still need to go ahead with further biopsies or continue. But I would take the surgeon's opinion also.
Right. Professor Tongakar, I mean, or Professor Gupta sir wants to say something. I mean,
no, I like to address this.
Yes,
we have a lot of experience in Vedanta. Since 2010, we are doing MPMRI, and before that, in AIMS also, I had experience of that. So the question is, you cannot 100% depend upon the PIRAD scoring only. You have to see other parameters also. And Palak has also mentioned that particular point. Wherever there is a doubt, the clinician should decide to do the biopsy or not to do the biopsy, because we have seen the patients where PIRAD 4 and 5 have also turned out to be no malignancy. There may be chronic prostatitis, there may be genitoglandomatous prostatitis. So we have seen all that. So the one question has come recently, can MRI replace the biopsy? Answer is no. It cannot replace the biopsy. Don't do radical prostatectomy on anybody without doing a biopsy. So that is the message, and I have seen that kind of scenario. The second question was asked, those patients who are on active surveillance, means they have been already proven cancer prostate, and if they are not showing any changes at the end of 1 year, then you can avoid that biopsy at the end of 1 year. You can wait for 1 year more or 1 year more, like that. Only one more point I want to make about both the Dr. Menon. I have a lot of regard for him, and Dr. Palak also. But the point I want to say is that reading these histopathology report or reading the MRI is like reading the horoscope for a man. For example, I'll tell you, as I have already mentioned for the MRI, same applies to pathology. Interpersonal variation in reporting. You can see both 10 to 15 or 20%, the report may change if two radiologists report the same MRI or pathologists also report the same Gleason scoring. The third thing is that there is a 15 to 20% upgrading of the cancer prostate in your needle biopsy and radical prostatectomy specimen. So that also shows where you have taken the biopsy actually, like that. We have seen patients 3 plus 3, 6 only, and they have metastasis. So somewhere we have missed it. Maybe the surgeon has missed hitting the proper biopsy, or the report may not have been done, or enough tissue is not given to him to do a proper reporting. So I'm not blaming anybody. Now, one more point I want to make as we are coming to a conclusion of this session about the Amle state presentation. No, these calculators are very good. There is no doubt, but they will only give you a percentage probability of the that particular group of the patient. But when you're talking of an individual patient, I think so you have to think a lot of other factors, and because this prediction may go wrong also. So it is good to tell the patient counseling point of view, but the outcome may be different in different individuals. And these calculators are made on the parameters of Sloan Kettering, American population, American disease, and all that. We don't know in our developing countries what kind of disease we are dealing. So we should also come out, we should analyze our own data and come out with our own calculator. And then only we can predict on these things. I think so. That was the summary I wanted to convey. So
yes, thank you, sir. Thank you very much. Nice comment. I really
one small thing.
On experience.
Yeah, shall I add something there?
Do you want to talk?
Hello.
On this matter?
Yes.
See, basically, if you look at the calculators, it's good to good for the clinician to know what to expect, and it's good for counseling of the patient. But let me give you a small example. There is a patient who's got a organ confined disease with a little bit of extra prostatic extension. So T3A with a PSA of say 30 and of 7, 4 plus 3, 7. So grade group 3. So in this patient, if you look at the calculators, it will tell you that the risk of extra prostatic extension is 60%, risk of metastasis is 60%, multimodality treatment required is 75%, and the biochemical recurrence rate is 75 to 80% at 5 years. Now, if you tell this to the patient, which patient is going to agree to have a radical prostatectomy? And this is a very typical scenario of locally advanced prostate cancer, where we know that the results of multimodality treatment are excellent. By the mammograms, then it's going to be very difficult for any patient to accept such listing. So, to do it, everything in perspective, and then tell the patient that the chance that you're going to be fine at the end of 10 years is good, 80% and above. So, then, you tell the patient, yes, they will put him off the treatment completely. That is one thing. And secondly, about the PSA, MRI, and pathology reporting, as you said, there is a lot of variation. Those of us who are sitting in tertiary centers, we get good reports. Those who are in smaller centers, they don't have access to this. And that's probably one of the reasons why active surveillance is not practiced very commonly in this country. As far as the patients on active surveillance, whether they should avoid a biopsy based on MRI, I don't think we can do that today, because MRI basically will not tell you the grade. And we know that in repeat biopsy, there is the grade is increased, then the patient should have intervention in terms of either radical prostatectomy or radiation therapy. So MRI can give that information. Today the gleason is 7, tomorrow it becomes 8. Also, in terms of the MRI can't tell you.
Right. Professor Salam sir, do you want to comment anything on this?
Absolutely. I'd like to thank all the speakers. They are outstanding. Youngers are better. I found Dr. Pollock and Dr. Yatasham did an excellent job, and the senior professionals, they did also very good. And my special thanks also to Ganesh Bakshi as well as Santosh. They are very, very good friend of mine, and I believe that they have done justice to our request. And at the end of the presentation, our foundation used to offer a golden medal and also a certificate. The certificate will reach to you online, but since you are online, we cannot pass on the golden medal. Sometimes later, when we'll be doing the physical conferences, certainly we'll be able to offer or get the chance to hand over these golden medals. So last time, a lot of confusions were there. Many confusions have been overruled, particularly Professor Gupta and Professor Tongaonkar has given their huge experiences, and they have given a very good elaboration. For example, without a biopsy, the treatment can be started in prostate cancer or not. In this situation, you would have to measure the risk possibility or risk stratification for the endocrine treatment also, because endocrine treatment can kill a patient if the patient has got a cardiac morbidity. He can die of cardiac event silently without knowing and without identifying that this is due to a treatment protocol. So that has also to be understood very clearly, and that has written consent has to be taken prior to giving such kind of therapies. So many issues were there. Some of the issues were discussed very well, and we think that all participants, we would like to thank them so much that without them, this masterclass would not be a successful one. So there, all of you are cordially invited to the second module, and second module is expected to cover the treatment protocol and the elaboration of the organ confined prostate. That is a big issue. Robotics, laparoscopic, open surgery, and radiation therapy. Huge gadgets are there, people are there. I hope that will be a very important session. So that will happen after 2 weeks.
May I ask, may I ask the panelists that what is the actually, we need all of you in the second meeting as well. So basically, is it the right time in 3:30 or 3 o'clock, or you want us to do anything in the afternoon or the evening? I mean, sir.
No, I suggest you the timings should be after 5 o'clock, because we are working here. So at least 5 o'clock we are working in the hospital. So today I am just sitting in the hospital only. I am not gone home. But it will be better after 5, 6, and 2 hour session should be there. Take the small topic at a time.
Okay. Is it possible that we can
otherwise,
start at
discussion will be less.
Dr. Jangir, can you ask? If it is at 9 o'clock, then it may be 2 hours.
So 9 o'clock is late because that is our dinner time and all that,
5 o'clock is
9 o'clock is too late.
5 o'clock is good for us.
Good for us.
5 o'clock is fine. 6 o'clock is
very good for us. No problem.
Or 5:30, because there is a because somebody say it finishes 5 o'clock.
And do it between Monday to Thursday, because Friday, Saturday, Sunday, there are a lot of webinars going on in India. So we are all busy all the time.
Yes.
Okay, sir. So again, we
can do it on Thursday.
Thank you all, Dr. Menon, Dr. Pallab, who are still present, bearing with us, and all the participants. We apologize. Dr. Professor Hai is also there, and Dr. Ganesh is there, as well as the whole participants. We are really enjoyed.
Thank you very much, Dr. Jangir.
Thank you all.
Thank you.
You are bearing with us all the time.
Bye bye.
Yes, bye
I
bye.
like to leave now.
Bye, sir.
Okay.
Stay
Bye-bye.
safe, strong, and also come back to the next webinar.
Inshallah.
Masterclass.
Thank you.
We
Thank you,
deliver one
Professor
time.
Kalam.
Thank you so much.